Please start the presentation, please.
Okay. Good afternoon, everybody. I'm a third year resident of family medicine. Today I'm going to present an interesting case. So, today's case is uh, a 54 years old female presenting with a pain at her right foot for 2 months. And this is the present illness. She, she's she stated that like two months before visiting the hospital, she said that she experienced sudden sharp pain in all of her toes of her right foot after standing up from squatting positions, and she said that the pain worsened when she walked, and she also felt numbness in her right calf and foot with difficulties in dorsiflexing her right ankle, but the symptoms like subsided like for 2 days. After 2 days, but she came to our hospital at the orthopedic outpatient clinics, and she was diagnosed with acute herniated nucleus pulposus. She was treated with ketorolac and dexamethasone. And after that, 1 month after that, she claimed that the pain in all of her toes of her right foot still persists, and she still complained of weakness in her toe extensions and dorsiflexsions of her right ankle. And then she went to a neurology clinic in a private hospital, and she was diagnosed as like a right peroneal neuropathy with neuropathic pain, and was given pregabalin, duloxetine, and vitamin B12. And after that, she visited our hospital in our outpatient clinic because she said that her pain in her all of her right toes worsened and aggravated at night. She reported increasing numbness of her right foot and weakness from her right ankle and below, and she was able to walk only like 50 meters before the pain worsened in her right calf, and wish this pain improved after resting. She also noticed that her right leg is more red than her left leg. And this is past history. Her underlying disease is hyperthyroidism, which she haven't take any medications for 1 year. She said that because she went back to her hometown in the countryside. And her past illness, she denied any past illness, past trauma, and she's not currently taking any medications or using any herbal medicines or taking any over-the-counter medications, and she denied any allergies as well. Social history, she was born in Kalasin province, but now she live in Banglamun in Chonburi, and she work as a salesperson, and she deny any use of alcohol, smoking, or recreational drugs. She deny any disease or illness among her family members. Um, this is the physical examinations. Her vital signs was unremarkable, and including her lungs, her heart, and abdomen was unremarkable. Um, the striking feature is at her extremities, at her right legs. Um, uh, there was erythematous and warm right leg with non-pitting edema, but no tenderness was noted. And ulcerated wound with cross size about 1.5 to 1.5 centimeters was noted at the plantar side of her third right toe. Um, Upon palpating her pulse, the popliteal arteries and posterior tibial arteries and dorsalis pedis arteries was weak. Her popliteal arteries for both legs was 1 plus, and for posterior tibial arteries and dorsalis pedis artery was 0 at her right foot. CNS, uh, the significant features was weakness in ankle dorsiflexions, long toe extensions, and ankle plantar flexions in both of her ankles. and there was a decrease in pinprick pain and temperature sensations of her right ankle and below. So, can I ask the floor what are the problem lists in this case?
Uh, the problem is 52 years old female with chronic pain at right foot is about 2 months and with a history of complication of life of right leg and PE and physical exam in positive weakness weakness at weakness of right ankle dorsiflexion ก็อะไร and weak pulse โอเคครับ
Any more problems? It, so, the problem is a 52 years old female presenting with pain at her right foot for 2 months and with other clinical features including claudications of her right leg, weakness of right ankle, dorsiflexions, numbness below right ankle levels, and swelling and redness, and ulcerated wound at her right leg and ulcerated wound at her right third toes and weak pulses in both of her lower extremities and hyperthyroidism. So how do we approach this case? So these are the tables of the differential diagnosis for leg pain or claudication. So we could separate it into 4 categories: neurologic, musculoskeletal, vascular, and other. Neurogenic is like are such as like spinal stenosis, peripheral neuropathy, and for musculoskeletal could be arthritis, even stress fractures, and vascular could be peripheral arterial diseases and chronic limb-threatening ischemia. For others, could be malignancies or restless leg syndrome. And since this patient reported claudication, so we have to differentiate between whether this is a true claudications or pseudo claudications, which uh, claudication and claudication like symptoms could be intermittent claudication, spinal stenosis, arthritis, venous congestions, and compartment syndromes. For this case, uh, it is we favor intermittent claudications because she reported pain at her calf. If we look at the locations from this table, and walking will reproduce these symptoms, and after resting, the symptoms will be relieved. And there was also a decreased pulse. So I think interclaudication is most likely in this case. So what are some differential diagnoses in this case? Can I ask the floor?
So the first differential diagnosis would be like chronic limb ischemia, and the second one might be like diabetic polyneuropathy. But it might favors to like chronic limb more than the diabetic polyneuropathy one because the weak pulse and uh and the intermittent claudication, the the diabetic polyneuropathy one, like they will be like less common.
Okay. So these are the differential diagnosis. The first one is chronic limb-threatening ischemia. Um, for the reason that favors this disease is because the patient has like weak pulses, and she also reported a history of intermittent claudications. There was an ulcerated wound at her right third toe for 2 weeks, and numbness and weakness below her right ankle and resting pain. But the some reason that goes against this diagnosis or like edema, because usually CLTI doesn't really have edema and warmness. The second differential diagnosis is the diabetic polyneuropathy, uh, because she has numbness and weakness below the right ankle, and weakness of dorsiflexion and ankle, and also ulcerated wound. But the cons are the weak pulse in both lower extremities and intermittent claudications. The last one is chronic venous insufficiencies because she reported there was non-pitting edema and warmness and redness, and it also reported claudication as well. But the reason that goes against this diagnosis is that the location of the ulcer. The ulcer for CVI or chronic venous insufficiencies is usually at the gaiter area, and other reasons are numbness, weakness, and weak pulse. That goes against this diagnosis. Other differential diagnosis could be like cellulitis and other infections. So the provisional diagnosis in this case is chronic limb-threatening ischemia of her right leg. So what are the further investigations that should be done in this case?
The Doppler ultrasound to evaluate the pulse, and the laboratory, the basic lab, CBC, BN creatinine, electrolyte, and coagulogram, and the thyroid function test because the patient has underlying hyperthyroidism. Okay.
Any more?
From the provisional diagnosis is CLTI, chronic limb-threatening ischemia. The gold standard of limb ischemia is about CTA, lower extremity.
Okay.
And I think this patient need to blood investigation for complete blood count and a thyroid function test and a coagulogram.
Oh, okay. So the investigation that were done in this case is the first one is Doppler ultrasound. And the striking features include there was a weakness in the pulse of the popliteal arteries, reported 1 plus, so and biphasic phase in her right legs and trifacet in left legs, and posterior tibial arteries with 0 and 0 in her right legs and 1 plus in her left leg, and dorsal pedis arteries reported 0 in both legs. And later on, CT lower extremity was done for her right and left legs, and as you can see in this arrow, this is the femoral arteries, and you can see that there is a clot inside, a thrombosis inside the arteries, comparing to the left femoral arteries. And this is the other view. As you can see this hypodense lesion here that represent like the thrombosis in her right femoral arteries. The official report was thrombus in right common femoral arteries and proximal of right superficial and deep femoral arteries. And there were delay in faint contrast opacity of bilateral dorsalis pedis arteries and at her right peroneal artery as well. And these are the laboratory features of the patients. The positive finding in this case is her thyroid, which is like hypothyroid. Her FT4, FT3 was high and her TSH was low. Her coagulogram was iron hours. Iron was likely it was a bit elevated. And other striking features are like are a creatinine a little bit low and HDL low HDL and HbA1c of 5.9, which is higher than normal. And so, according to the Rutherford classifications for chronic limb ischemia, and she had non-healing ulcers, so it should be at least like grade 3 or category 5. So in this case, we could diagnose. Oh, sorry, this is the EKG of the patients. The EKG of the patients was reported as there was atrial fibrillations. The rate was irregular and rate 135, and there was no PVF seen and no significant ST change. And there was a right bundle branch block as well. The diagnosis in this case were chronic limb-threatening ischemia of the right leg, hypothyroidism, atrial fibrillations with rapid ventricular response. So before we go to the management of this case, I will talk about what is chronic limb-threatening ischemia and the management. So chronic limb-threatening ischemia is a subset of peripheral arterial disease. It is considered as like the end stage of the peripheral arterial diseases. Other diseases include includes acute limb ischemia or chronic symptomatic in this case, or chronic limb ischemia. So the definitions of chronic limb-threatening ischemia, according to the American Heart Associations, they said that it is patients with known proven arterial occlusive disease with combinations of symptoms such as rest pain, gangrene, or lower limb ulcerations that last more than 2 weeks. The most common cause is atherosclerosis, and the risk factor goes along with atherosclerosis, like smoking, DM, hypertension. But this also includes like other diseases like chronic kidney diseases, air pollutions, or a family history of peripheral artery diseases. CLTI or chronic limb-threatening ischemia is considered a highly disease that cause like high morbidity with amputation rate if left untreated for up to like 30% within 1 year. Signs and symptoms of this disease includes like loss of hair, brittle nails, dependent rebore, which is like redness and swelling of the foot if you you don't elevate it, and muscle atrophies and cold extremities and weak pulses, intermittent claudications. These symptoms are symptoms of like chronic limb ischemia. If you want to diagnose a chronic limb-threatening ischemia, there must be like ischemic rest pain, ischemic ulcerations, and gangrene, which this patient has like ulceration and resting pain. And this is the pictures of ulcerations. It is the patient has ulceration like these pictures, but no gangrene yet. Site of occlusions could we can guess the site of occlusion based on the location of the claudications. The most common location is the distal superficial femoral arteries that cause upper two-third calf claudications. Other locations are like aortoiliac arteries that cause buttock and hip claudications, popliteal arteries that cause lower one-third calf claudications, and both posterior tibial and dorsalis pedis artery cause foot and ankle claudications. So if we suspect patients with CLTI, what should we do? According to the 2024 American Heart Association guidelines, we should perform ABI. ABI is an ankle brachial index, which I will talk about it later. And if this ABI is lower than 0.9, the patient has risk of having CLTI. And we could confirm using TBI, toe brachial index, and use other modalities like duplex ultrasound, CTA, MRI. For investigations, I will separate them into non-invasive and imaging. So the non-invasive includes ankle brachial index or ABI, toe brachial index, TBI, and transcutaneous oxygen tensions. Other include segmental limb pressures and pulse volume recording. For the ABI, it's to calculate ABI, we will measure the blood pressures of first we will measure the blood pressure of the legs, the ankle, the ankle of the side that you want to measure, and then you will measure the systolic pressure of both left and right arm, and use the one with the highest systolic blood pressure as the denominator in these equations. And to interpret, abnormal is lower than 0.9. And for toe brachial index is similar to the ABI, but instead of measuring the blood pressure in the ankle, you do it in the toe instead, using Doppler ultrasound to listen to the pulse in this case. And the abnormal value is below 0.7. Our hospital have ABI as well at the rehabilitation clinic. The queue is like 3 months. Other investigations include duplex ultrasound, CTA, MRI, contrast angiography, which is still considered as a gold standard, but we don't really do it that often now because we have CTA instead. And other include like digital subtraction angiography. So this is the example of DSA or digital subtractor angiography. And for treatment, treatment according to the guidelines, it involves like multi-specialty care team where included vascular surgeons, rehabilitations, and even nurse. And then the goal is to revascularize the clotted arteries using surgeries or in even endovascular approach. Other include wound care and management of infections and pressure offloading, and amputation if the tissues are not viable, and other include antiplatelets and anti-thrombotic therapies. So according to American guidelines, when you suspect the patients with CLTI, you have the first thing that you have to do is to stage the severities. The GDMT is like to see whether the patient is a good candidate for revascularizations, which they will refer to the other guidelines and the other kind of classifications, which I will talk about it later. If the patient is a candidate for revascularizations, there will be some discussion among like multi-specialty care. And firstly, they will perform wound care and management of the foot infection first. And if the patient is suitable for revascularizations, they will perform either surgery or endovascular approach. But if the patient is not a candidate for revascularizations and the tissues is not viable, the decision have to be made like whether to amputate or not to amputate. So it's according to like the patients, or the age of the patients. Like some geriatric patients won't do it, or some like patients with like cancer, like stage 4 cancer, will not do it, something like that. And for the one that I said that they refer to other guidelines and other classifications, they refer to the European classifications, this diagram. So firstly, if the patient have CLTI, you have to stage the severity of the limb. So they will use the WIFI stage. If I will talk about it again later, and if the stage is more than 2, you have to see whether the patient is like the candidate for limb salvaging. And if the patient is the candidate, in this case is if the patient will survive 2 years after the surgeries, they will perform the revascularizations. But if not, they will do only like wound care and like to manage the infections and wound instead. So if the patient is the candidate for limb salvage, revascularizations, they will perform like the anatomic staging of the disease, and they will choose the method of surgery based on this staging. So this is the way to calculate the staging, the classification staging. It is called a wound ischemia and foot infections. So there are 3 variables that you have to look at: is the wound, whether the patient have the ulcer, the degrees of the ulcer, the ischemia based on ABI or TBI, and foot infection is based on like the clinical symptoms that you see. And so if the patients have like at least stage 2, the benefits of revascularization is not that high, but above stage 2, so stage 3 and 4, the benefit is quite high, and they will usually consider a revascularizations. So the management in this case is first consultation to surgeon was done, and then the surgeon, they give the patient heparin. They said to prevent further clotting, for the elongations of the clot, and giving oxygen because because there is really a limited amount of blood to the area, so they try to make that little amount of blood have like as much oxygen as possible, and then they perform an arterectomy. Before surgery, they also consult an endocrinologist for any pre-medications for her hyperthyroid before this, including CTA and before surgery. So she was giving PTU and amiodarone to control her atrial fibrillations and enoxaparin because in this case, the CHA2DS2-VASc score was 3, so they give it as thromboembolic prophylaxis. And after the surgery, her pulse improved. All of her pulse was 2+ from 0 at her PTA and DPA arteries, and there was also a reported improvement in the discoloration of her right distal leg. And that is all for this case. Do you have any questions?มีมีอาจารย์ท่านไหนอยากเพิ่มเติมอะไรไหมครับ
For assessment in the primary care setting, I think the key in this case is to determine that there is an emergency condition that you need urgent treatment or not. Okay. After that, you rule out. After you rule out emergency conditions, you can proceed to the differential diagnosis. For me, the main differential diagnosis that you need to concern can be divided into three categories. The main cause, the main common cause is atherosclerosis, and the second one is thrombotic occlusion, and the third one is non-atherosclerotic arterial disease, such as Berger disease, vasculitis, Takayasu, polyarteritis nodosa, and fibromuscular dysplasia. And then we treat accordingly to the underlying etiology. Okay. I think for family setting, the main and the key for the case is to determine the emergency conditions. And for window, you did very well, concise, and well summarized. Thank you.
Thank you very much. มีอาจารย์ท่านไหนอยากเสริมอะไรอีกไหมครับ ก็ถ้าไม่มีอาจารย์ท่านไหนอยากเสริมอะไรแล้วก็ขออนุญาตปิดคอนเฟอเรนซ์วันนี้ครับ ขอบคุณครับอาจารย์